So first of all, thank you very much for joining us today. This is the first ever webinar of the Global Observatory of Long-Term Care, and this webinar has been organized by one of our first and very active interest groups, which is the Data Science Group. I'm Adelina Comas-Herrera, and the director of the Global Observatory of Long-Term Care, which is an initiative of the International Long-Term Care Policy Network based at the London School of Economics at the Care Policy and Evaluation Center. And I'm going to briefly introduce the observatory, then we'll hear a little bit about the Data Science Interest Group. We'll have a presentation from Ulrike Famira-Mühlberger, and then we'll have a bit of a discussion with the leaders of the interest group on how to engage. So I'm going to see if I get to share my presentation. And I think it's going to work. It is always fantastic. So yeah, this is called basically the Global Observatory of Long-Term Care. And the motivation for this, well, I think we all know that we are aging all over the world, which means that long-term care systems will need more and more better prepared systems to respond to bigger need for accessible, affordable, high quality long-term care need. But we know that very few countries, even well-off countries, are not quite there in terms of having the kind of systems that we might need for the future. And this became quite clear during the pandemic. And what this observatory has been very much motivated by an initiative called GOLTC COVID that many of you, and I've already seen quite a lot of familiar faces, were involved. And we started by, first of all, trying to shine a light at what was happening in care homes. And we started using the platform of the International Long-Term Care Policy Network, started as a blog, then became quite a big website. But we were trying to record in real time what was happening and what we knew, and shine a light on what was happening in care homes, and also more generally then in long-term care systems and in helping people access care in the context of the pandemic and in a context in which the care sector in many countries seemed to have been forgotten. So we started even collecting newspaper reports. Then we started to have reports on what was happening on every country and sharing early evidence. And this was a very, very influential initiative. Here is a collection of newspaper articles, but also our work was also picked up in speeches by WHO and the UN. And it was, I think, a really important way in which the research community in long-term care mobilized. And it seemed a good idea to build on this. After the initial saying that it was very important to understand what was happening in the care sector, we went on to produce 37 country reports. The website had almost 500,000 visits. So it's clearly worth building on this. And of course, we are now in a different situation, and we're not, COVID is still there, but perhaps not as an emergency. So the idea was to pivot to a more comprehensive view of long-term care systems and providing a network and a platform to help us continue to share learning on how to improve and strengthen care systems. This is still part of the International Long-Term Care Policy Network, and the idea is to share key challenges, but also facilitate collaboration, share research evidence, and also learn together, which I think is an example of what we are going to do today. And this is very open to anyone who wants to join. And in terms of how to engage with the Global Observatory of Long-Term Care, well, we have the link to the website here. And the first thing to do is to create an expert profile. And if you're here, I am sure you qualify as an expert. And we'll be, I think, sharing the link in the chat as well, so you can join us. Once you create a profile, then you can access the groups that we have in the website. And at the moment, we are hearing today from the data science interest groups. We have a few more. And in fact, the quasi-experimental methods group will be hosting the next webinar very soon. Here you can have a view of the experts directory. And I should say that if you want to find out what we're doing, but you don't want to be quite as involved, you can also sign up for the monthly newsletter. There is a box at the front of the website. Our next webinar is on the 24th of January. and we'll be looking at the preferences on aging in place with some work from Spain, will be presented by Cristina Villaplana Prieto, as a very interesting version. We are also very happy to have this other very active group, which is the post-experimental methods groups. We're very open for suggestions of more interest groups. You can let us know if you're interested. You can put something on the chat, or you can send us an email. And I'm just going to mention as well that we're very happy to announce that the next International Long-Term Care Policy Network Conference will be in Bilbao in September. And we very much hope that this will be an opportunity for some of the interest groups to be able to meet in person and perhaps even have organized sessions. So keep that date in your diaries. And that's all from me. Thank you very much. And look forward to see how this group shapes up. And you're going to be invited to answer a poll at some point, if it hasn't happened yet while I was speaking. Thank you.
Thanks for that, Adelina. So yeah, hi everyone. My name is Sam Rickman, and I am I'm the lead for the Data Science Network. I'm just going to try to share my screen just to give you a brief overview of the rest of the event. Hopefully you can see this. So essentially, it's really exciting to see so many people here. So thanks everyone for attending, and obviously to Adelina and the GOLTC team, and to Ulrike for presenting. We're going to have Ulrike's presentation. That's the main part of this event, but because this is the first meeting of the data science interest group, we really want to find out what people would like from the group, those of you who are interested in future events. So after Ulrike has spoken, so we have a couple of polls. I think the first one has come up, and maybe we can put the second one up around now as well. And then after Ulrike has spoken, the last sort of 10 or 15 minutes, I'll just go through how we're hoping to get some feedback from people about what you would like from the group. But first, so we'll have Ulrike's presentation, Ulrike Famira-Mühlberger, who is a senior economist at the Austrian Institute of Economic Research, who focuses on socioeconomic aspects of long-term care. Ulrike is presenting a paper which uses administrative data from the Austrian cash for care system to predict receipt of long-term care allowance. So Ulrike will speak for about 15 to 20 minutes, and then we'll have about 10 minutes of questions. So feel free to put questions in the chat, and I can put them to Ulrike at the end. Alternatively, put your hand up and we'll try to ask people in order. So I'll stop sharing now and hand over to Ulrike.
Yeah, welcome, and thanks a lot. Thanks a lot for having me. I'm happy that I can present our work here. When I agreed to do this presentation, I did not know that so many people would sign up. So thanks a lot, and yeah, I hope that you find it interesting. So I will share my screen. Okay, does it work?
Yes.
Yes.
Works.
Okay, fine. Thank you. Okay, so this is joint work with a colleague of mine, with Klaus Nowotny. He's currently teaching, so unfortunately he can't join us. But yeah, I want to mention that this is joint work. So I present the results of a study that we did for the Austrian Social Insurance Institution. And that's basically why we got access to this administrative data. In this study, we analyzed the correlation between the health history of people aged 60 plus and we have three parts. So the correlation between the health history of people and the entry into the long-term care allowance scheme for the first time. That's the first part. The second part is we analyze the correlation of the health history and the change of the long-term care allowance level. And in the third part, we analyze the correlation between the health history and the transfer to residential care. So we worked with pseudonymized health service data from 2015 to 2018, and with long-term care allowance data from 2016 to 2018. So first of all, I want to give you a short overview of the Austrian long-term care allowance system. In 1993, Austria introduced a uniform needs but not means tested long-term care allowance system, the so-called Pflegegeld. There are three levels depending on the intensity of care needed, and the allowance ranges between 175 euro per month at level 1 to roughly 1,900 euro per month at level 7. So 50% of those receiving long-term care allowance are assigned to level 1 and 2. And all in all, about 5% of the Austrian population receives long-term care allowance. Among those who are 65 plus, more than a fifth received the allowance, and among those who are 80 plus, about half receive the long-term care allowance. And it is financed by the general federal tax revenues, meaning by the national budget. For our analysis, we use pseudonymized individual data of more than 550,000 recipients of long-term care allowance aged 60 plus between 2016 and 2018. We have a case control group of over 400,000 persons that are aged between 60 and 85 without the long-term care allowance between this period. We have data on age, we have data on gender, on NUTS 3 region, and we have the data of the number of contacts with GPs, with specialized physicians or other contractual partners. We have data on dispensed remedies, prescribed drugs, and of the main diagnosis according to the ICD-10 and individual medical services provided, but those only for the hospital stays. So in sum, we have a total of more than 3,600 potential variables. So basically, we examine the following. How likely is an event in the event period, given the personal characteristics of a person and the health services consumed in the observation period? So we do an exploratory data analysis with machine learning methods. We run logic regressions using the lasso method to reduce overfitting problems. And the lasso method is, in fact, a method that helps us to select the most important variables, so with the highest correlation. We use 75% of the data to train the data in order to optimize the statistical method, and the assessment of the model quality is based on the test data that is the 25% of the data set. So our results, and that's important to add, our results do not allow for causal interpretation. We show only statistical correlation with that. So the first research question in our study was whether we can predict the first time receipt of long-term care allowance with the health data. And the answer is that we can do that fairly well, especially when the event period is relatively short and the length of the event and the observation period have roughly the same length. So here you see the resulting ROC curve, and the ROC curve, which comes from receiver operating characteristics. So ROC curves are used to compare the true positive rate of a classification method, which is called the sensitivity, with its false positive rate or the failure rate. And in general, models with the highest possible sensitivity and the lowest possible failure rate are those who are desirable. And models with an area under the curve, which is the AUC, the area under the curve, is close to 1 when the model has a good fit. And models with an AUC, an area under the curve between 0.8 and 0.9, what we have here, can be said to have an excellent discriminatory power. So we can predict first-time receipt of long-term care allowance well from the individual health data, especially in the short run. So we see that the model quality deteriorates if the month before the first receipt of the long-term care allowance is omitted. And we also see that a higher level of detail in the measurement of healthcare services leads only to a slight increase in forecast quality. However, a high absolute number of potential false positive classification limits the possibility of using it as a leading indicator. And that was the idea of the contract partner, that they wanted to show, or they wanted to know whether the data allows something like an early warning system for the future receipt of long-term care benefits at an individual level. In fact, so our analysis does not allow that, because the events analyzed are not evenly distributed in the available data, and also not in the underlying basic population. So that means that we would have too many false positive classifications, and the model would wrongly distribute too many people to the group of first-time recipients. Here you see the characteristics that correlate most strongly with the first-time receipt of long-term care allowance. So I only mentioned the first 3 because we have many other slides. So we see that all things equal, age is the most important characteristic. And secondly, the days in inpatient treatment in the year before, the event period is the second most important characteristic, followed by the appointments, by the number of appointments with a GP. In the second part, we analyzed the most important determinants for the transition to a higher level of long-term care allowance on the basis of health service data like before, and taking into account also the personal characteristics. We work with, in this part, with the same data as before. The event period is the year 2017, and within this period, 18% of the long-term care allowance recipients transferred to a higher level of long-term care allowance. And the observation period is the year before, the year 2016. And we do multivariate analysis based on lasso regression, and the lasso regression here helps us once again to select the variables, and it selects the most important variables. And here you see the most important characteristics when moving to a higher level of long-term care allowance. So first, the long-term care allowance level in the month before the event has a negative impact. So that means that the higher the level, the less likely it is to move to an even higher level. Second, we see a positive correlation with age. And third, we see drugs that are connected to dementia-related diseases as important variables here. In the third part, we analyze the most important determinants before entering residential care on the basis of health service data as before, and also on the basis of personal characteristics. Once again, we use the same data. The event period is 2017. And within this period, as in the year 2017, 8% of the recipients of long-term care allowance enter residential care. And the observation period is the period before, and we use the same methods as before, the lasso regression. And here you see the most important characteristics that have an effect on transfers to residential care. Most important is the long-term care allowance level in the month before the event, followed by appointments with a GP, and third, with age. Here we also see, maybe I mentioned that as well, we also see that in some regions it is more likely to move to residential care than in other regions, and so then with a health the same health characteristics. Okay, to sum up, so the first time receipt of long-term care allowance can be predicted quite well from individual health data, especially in the short run, but we can't use it, at least not with the methods we used. We can't use it as an early warning system. We see that age is of high relevance. So the question is whether age is has a big importance here in granting long-term care allowance or in moving to a higher level. On the other hand, you could argue that age probably capture things that we can't see in the data otherwise. We also see the importance of dementia. So I only mentioned the first three characteristics that are important in the different parts, but when we look at the first 10 or 15, we see that dementia is here very important, which calls for a bigger focus, a stronger focus, political focus on prevention. What's interesting is that we see a regional divide. So we see that we have a higher incidence in some regions, ceteris paribus, but we have to do more research in order to know why this is the case. So maybe in the third part, when moving to a residential home, a residential care home, maybe it's a question of how many homes are available, but with the other two parts, or whether people move into the long-term care allowance system or move up the levels. In fact, we can't see why there's a difference between the region, because we control for age, for the region, for and for health characteristics. Yeah, so I think it was bigger and it was quicker than I thought. So I would be finished. Thanks a lot for your interest, and I'm looking forward to your comments.
Thanks very much for that, Ulrike. That was really interesting. I wonder if I could just kick off with a question. So I think one thing that's interesting is that I think it was in your second in your second set of results, the transitions to higher levels of allowance. One of the predictors, you mentioned dementia, one of the predictors was anti-dementia drugs, and one of the predictors was a diagnosis of dementia, and they have different strengths. And I guess one interpretation of that is that, you know, I don't know, more people are in one group than in the other group, and another interpretation of that is that perhaps the diagnosis of dementia is not recorded as faithfully as whether or not a person has a particular medication. And I guess this is often a challenge with administrative records, using the data from administrative records. How do you interpret things like this when you know that the purpose of the recording, and that there are lots of cultural issues in how things are recorded, and the purpose is not for research? I mean, how did you sort of think about those kinds of issues when interpreting your results?
Yeah, I mean, I think you relate to that, to the second part. Yeah, of course, you're right that so that there are problems with administrative data, also concerning how we interpret the results. Here, what we see is, in fact, all these criteria are drugs that are prescribed and that are usually connected to dementia-related diseases. But in fact, we don't know why they have been prescribed. So there are many different possibilities. We don't know, in fact, which diseases are really, behind those. But what we know, so these are the drugs that are really prescribed. We don't know whether these are drugs that are really have been taken then, but we know that these are the drugs that have been prescribed.
Great, thank you. I wonder if there are any other questions. I can't see anything in the chat. Oh, Javiera.
Hi, thank you very much. It was really interesting. I have not much experience in machine learning, but similar techniques. But I was wondering, when you show these 15 most important factors, just because I'm thinking more like a decomposition analysis, when affect the order that you add these factors kind of affect which one is more important. So I'm wondering, in machine learning, do you put all the factors in one bag and then the model tell you which one is more important, or you go and try one by one and then check which one is more important?
No. For the first. So we use this lasso method, and we use all the variables, and the lasso method helps us, comes up with the most important ones. Okay, and here in these slides, I have shown the most important, the 15 most important ones. Yeah. that's the that's the advantage of this method when you have a lot of observations and a lot of variables that can explain part of the results. Then you can use the lasso method, and that helps to distinguish between the most important ones and those who are not important.
And you don't need to worry about how correlated are these factors within each other. You just put them all together. You don't
exactly, yeah.
Okay.
Yeah, absolutely. I think that's the I mean, that's kind of the purpose of the method is to deal with when you have a large number of potentially highly correlated indicators. So yeah, I mean, lasso stands for, I think, least absolute shrinkage. I can't remember what the S and the O are for, but it's about basically, I mean, essentially it is to do exactly what you've done here, Ulrike. I mean, to sort of pick out the most important indicators by increasing the loss when you introduce more indicators which may be correlated. The next question, I think, was from Vanessa.
Hi. Thank you very much for the presentation. I just wondered, you said that the people that commissioned the research were interested in developing something that could work as an early warning system, and you discovered that that wouldn't be possible with the indicators that you had and with the analyses. So did you then go on to think about what types of data might be useful in establishing that kind of early warning system? Did you get as far as having conversations about, you know, data beyond sort of health data that might or could possibly be collected by care providers, or did you have any of that kind of discussion?
Not really, because yeah, the national, so the Austrian insurance institution, so they have the data on the health recordings, and they have also the data on the long-term care allowance. And yeah, and in the end, so they wanted to know whether they could build such an indicator with the data they have. The thing is that so it's that we've seen that we can't do it with the methods we used. So maybe, but we didn't go so far now. Maybe there are other methods that can predict or build an early warning indicator in a better way, but not with the data and methods we have. But it was not a discussion, but it's a good question, yeah. But it was not a discussion which form of data or methods we would need in order to do that. But in the end, so it's not, so we see that we have, so we can predict it quite well, but not in form of an early warning indicator, because on the individual level, we would have a problem with the assignment.
Yeah, thank you.
Thanks for that. Yes, next is, but if anyone else does have a question, by the way, I'm just coming to them in the order that people are putting their hands up. So do put your hand up or put it in the chat. Bo, you were next.
We don't hear you.
Thank you for this very interesting presentation. And my question also relates to that early warning system. And if my understanding is correct, that you mentioned that this is because your false positive is too high, and the false positive is too high because the proportion of people receiving allowance is too small in your data set. Is that you think the reason for the false positive?
No, the reason is basically that the distribution of people receiving long-term care allowance is too uneven. So that's methodology from a methodological perspective, the main reason.
Does it mean that you have many
That's
more people who are not receiving allowance than people receiving allowance? So the two categories, they are uneven. Is that the you think that because of the reason of the false positives?
Yeah, I mean the main reason. The main reason is the distribution of the event. So the distribution of people receiving long-term care allowance. Which the distribution is not even, which means that on the individual level we have the risk of a misclassification.
And whether you have tried to downsample the majority category which is not receiving allowance, so that you can have a matched sample from those people who are not receiving allowance. You just randomly select a sample. So say if you have 100 or 200 or 1,000 people receiving allowance, you have 10,000 people not receiving allowance. From those 10,000, you randomly select 10,000 people not receiving allowance, so that they can be a match for those receiving allowance. Then you have 50-50 divide between those not receiving allowance and those receiving allowance. And on that downsampled data set, then rerun your machine learning models, whether that would, to some extent, reduce the false positive problem.
Okay.
Thanks, Bo. That is definitely something that does sometimes work and sometimes doesn't. We've got at most about 5 more minutes of questions. So let's next, I think June, I should say. Sorry, June is on the steering group, and I think you're the only one who doesn't have a background. I only got it a few minutes before the meeting. We'll get a few next time. What was your question, June?
Yeah, thanks for amazing presentation. I really enjoyed this presentation. And then my question is that not the actual question, the suggestion is that to improve the predict performance, and then you in this study you only utilize the administrative data. So adding to the Vanessa's question, so probably you can consider to use some clinical notes utilizing the natural language processing to improve the predictive ability in the next time. So I just like if it is possible in Australia, probably you can think about that.
Yeah. The problem is just that so in Austria with administrative data, with data on long-term care, it's quite tricky to get access and also to get additional data. But we have a new project which probably allows us to use more data on this whole data set of long-term care in Austria, because there are more variables that we could use. But we were not allowed to use that for this research I presented here. But we start with a new project that allows us to use more variables of this data set.
Also, I'm looking forward to seeing that. Thanks.
That sounds very interesting. Jose Luis?
Thank you very much, and thank you for a very interesting presentation. So I was wondering, in terms of your dependent variable, you lose quite a lot of information by having this dichotomous indicator. And I've actually just seen somebody putting a very similar question on the chat. Have you considered survival models, competing risks models, or also looking at not whether you use long-term care, but the cumulative expenditure? Because in some ways, what governments want is also to target those people that are going to cost a lot of money.
So you mean to differentiate between the type of care they need?
So to predict length of time before utilization, rather than it will give you.
Yeah. Okay. Yeah, that's a good point, but that was not a research question here, but that's, of course, that's very important how long they are in the system, yeah. Mm.
Thanks, Adelina. Yes, that would be interesting, and it's the very similar question to Megan's question in the chat. There was one more person with their hand up, which we just about have time for, Madeline, but the hand's now disappeared. Was there a question there?
Hi, thank you for the presentation. I just wanted to know, because you analyzed lots of health data, but I don't know if you analyze some more social kind of variables. And I wonder whether, for example, the living situation, whether the person lives with another person or is living alone, could impact the receipt of long-term care. That was my question. Thank you.
Absolutely, absolutely. But we didn't have access to these variables. That's what we try with the new project. And for this project, we get access to more variables. But so far, we didn't have that access, yeah. But that's a good point, yeah, thanks.
Great. Well, thank you. Thanks for all those questions, and thanks very much for that really interesting presentation, Ulrike. And I think that last question about sort of the availability of data brings us quite well into the next part of this webinar, the last sort of 15 minutes or so, where we sort of talk about what people would like from this group. So I'll just share my screen again. Hopefully you can see this. Oh yes, great. Another poll. This is the last poll. We have a lot of ideas as the steering group about what the group would look like. I mean, the ultimate purpose is to bring people together, academics and policymakers, to share methods, share insights into the right types of questions and how to best answer those questions to improve the quality of research and the impact of that research. But what exactly that looks like depends, and we've got a lot of ideas. Obviously, presentations like Ulrike's are really valuable. Also, on the website, we will be putting together a hub of relevant papers. We've also started to put together some resources. So this is the first one, and this is on the GOLTC website as well. So this is a sort of resource for how to communicate the findings of research, and the idea of these resources is that they'll have code in the resources, so it's entirely reproducible, sort of how to actually recreate these things. But what we want to find out is so it's partly about the format. You know, what do people like? Are things like that useful? Would that be better as a presentation in itself or a video? And also much more about what are the actual topics of interest. Now, because there are quite a lot of people in the webinar, what we've done is, so we're going to split into breakout groups. Each group will have a topic, and then what I'm hoping is that every group can nominate a person. We'll share the link in the chat for this, which is the Padlet, and then somebody in each group, I hope, will take it upon themselves to simply add a couple of notes from what their group has discussed. So, for example, you might say interested in ethics and bias in models, and if you're in this group, and then that could be published there, and then that will hopefully give us a sense of the direction for the group. So perhaps we can split into the breakout groups now, and that will be for about 10 minutes, and then that will take us broadly to the end of the webinar. I'm hoping that the Welcome back, everyone. So we are very much out of time. I noticed a flurry of activity on the Padlet, and that link will remain open for the next day or so. So if there's anything that people would like to add, please do. We will be very much monitoring it over the next 24 hours before we make any other plans. Yeah, but we are at the end of the session. I should say the next GOLTC webinar is on the 24th of January, and that's quasi-experimental methods, and the details are on the GOLTC website. Thanks very much, everyone, for coming along and for asking all of the questions. Your questions and engagement have made this very much worth doing, and we will have our own another data science webinar probably in late February or early March next year. So thanks very much for attending, and thank you to Ulrike for her presentation, and see you all at the next one.
Thank you. Bye-bye.
Bye.
Thank you very much.
Thank you.
Bye.
Bye.